Welcome everybody to this webinar organized by EURO-NMD in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. Today we are going to learn about respiratory insufficiency in neuromuscular disease and mainly how to deal with it. We have the chance of having with us Maxwell Damian, who is a Tasmanian-born neurologist who studied medicine in Germany and UK, where he's based, and is also accredited as a clinical neurophysiologist and an intensive care expert. His clinical and research focus is muscle disease and neurocritical care. He retired from full-time work in the NHS as a consultant neurologist at the Cambridge University Hospitals in 2020, and now works part-time in critical care at the Access Cardiothoracic Centre in the UK on multimodal neuroprognostication and remote neuromonitoring. He's a fellow of the European Academy of Neurology, where he chaired the Neurocritical Care Specialist Society, and is also a member of the American Neurocritical Care Society. During the COVID-19 pandemic, collated the World Muscle Society at COVID-19 advice and practice parameter publications, and has since been involved in developing telemedicine in the care of muscle disease patients. He's co-editor of the textbook Emergencies in Neuromuscular Disease that was edited in 2022, and of a further textbook on neurorespiratory medicine that is in preparation. So, Max, thank you very much for taking the time to teach us precious learnings about this important matter, and the floor is entirely yours. Thank you.
Well, thank you much, Antonio, and thank you very much to the organizers for asking me to speak here. Now, we were just chatting before this meeting, and respiratory and critical care in neuromuscular disease has always been a slightly niche interest, because respiratory failure was considered up to a few years ago, really, as sort of the end of the road for neuromuscular patients, and therefore management was of considered less importance than it possibly was. And now I'm going to talk about the developments in monitoring of neuromuscular disease and respiratory care, and about its management, which has gained importance as treatments for neuromuscular disease have evolved. Now, let me see, can I?
Yeah, you can.
Yeah, that's it. Here we go. So briefly to the background of this talk. Now, respiratory failure, together with heart disease, is one of the leading causes of emergencies and death in neuromuscular patients, generally speaking. And it's not true that it always develops late in advanced disease. There are some neuromuscular disorders where respiratory involvement occurs very early, even the initial presentation. So these patients may be quite mobile. Respiratory muscles assessment should therefore be a central part of neuromuscular care in the clinic already before emergencies arise. And if we achieve better respiratory monitoring and management, we manage progression and complications better, and we prolong survival and also improve quality of life. So I consider it a fairly important topic. Now, first of all, a little bit about the anatomical and physiological basis of respiration from a neurological point of view as a whole. So as you know, the respiratory centers in the brain stem connect to the spinal cord, and then from there via the phrenic nerve and intercostal nerves to the respiratory muscles. And at each of these levels, specific conditions can cause respiratory failure, from brainstem disorders, spinal cord damage, and then peripheral nerve and also muscle disease. And it's important to have an understanding of the respiratory mechanics, as you see from this image. Now, centering on the muscles involved in breathing, you can separate the muscles of inspiration, the principal one being the diaphragm, but also important are the external intercostals that lift the ribs, and the parasternal muscles. And there are also accessory inspiratory muscles such as the neck muscles and shoulder muscles that can help take over if you, say, have paralysis or failure of the diaphragm. Expiration, on the other hand, if we're in quiet breathing, not physically active, occurs via passive recoil of the inflated lungs. But then for deep breathing in physical activity, you need muscles as well. The internal intercostals are important here, but also muscles outside the chest, the abdominal muscles, because you need an intact belly band in order to create the pressures needed for active breathing. What happens with failure of the respiratory pump? Well, you can separate this into acute failure of respiratory pump function. That means that when the primary muscles, the diaphragm, primarily fails, you need your accessory breathing muscles, and this is visible clinically. If you don't inflate the lungs properly, then the alveoli are not properly inflated, they are deployed less, and then you get shutdown of parts of the lung, oxygen shunting, and your gas exchange is poor, apart from having risk of infection longer term. So patients whose respiratory pump is weaker first become tachypnic, they breathe quicker, but this, of course, increases the work of breathing and leads to later failure again. If you breathe quickly, your carbon dioxide in the blood will decrease, but then with more severe failure, the PaCO2 will increase again in the blood, and you get a sort of false normalization of your carbon dioxide, which is a sign that the system is beginning to fail acutely. And that's something to watch out in the monitoring of a patient with acute muscle weakness on the ward. Now, there are also subacute and chronic effects of failure of the respiratory pump. Oropharyngeal weakness will weaken your cough, and it will increase the likelihood of aspiration, and that leads to more frequent and severe pulmonary infections. Weakness of bulbar muscles chronically will result in breathing problems while asleep, starting with the common sleep apnea to hypoventilation when supine. And in addition, early onset neuromuscular diseases, particularly spinal muscular atrophies or congenital myopathies, also weaken the thoracic muscles, causing chest deformity, scoliosis, and that leads to reduced compliance of the chest to breathing, even when the respiratory muscles are weak as well, causing additional problems, as you know, from young patients with neuromuscular disease. So there are a host of different effects from the muscle failure involved in neuromuscular disease. Now, how should we assess these patients clinically? There are a lot of simple tests which are, when we observe them properly, will give us a great deal of information on the respiratory status, even without formal testing. You listen to the patient, you judge their clarity of voice, their ability to speak a full sentence without taking breath, or you let them count in one breath and can simply assess the depth of breathing by the how far they get counting. Let's say if you're using metronomic 1 per second counts, then you count to 20 is a good first test. You can also judge whether patients are able to lie flat, because in flat supine position, the diaphragmatic weakness becomes more obvious. You judge their strength of swallow, their cough, and head flexion and head movement more or less correlates quite often with respiratory muscle weakness, certainly with accessory muscle weakness. Of course, we need to note tachypnea or orthopnea, which means the patient cannot lie flat and needs to sit up straight. And we observe the use of auxiliary respiratory muscles using shoulder and neck muscles in order to inflate the lungs rather than just the primary respiratory muscles. An impressive clinical sign is paradoxical breathing, which you could also known as thoracoabdominal asynchrony, where there is severe weakness of the diaphragm and abdominal muscles. That means that with inspiration, the abdomen is pulled inward rather than pushed outward by the inflating lung. And in expiration, you develop abdominal distension by increasing the pressure in the lungs rather than expelling the air from the lungs properly. However, with this assessment, you need to know that the clinical findings adapt somewhat to the chronicity of the disorder. So in a patient with an acute respiratory pump failure, you will see these signs quite obviously, but in a chronic condition, there are a few signs until very late terminal respiratory failure. And in patients where the disorders develop stepwise progressively, the indicators of chronic hyperventilation might not be present for a very long time. And that's where it's important for us to perform formal testing regularly. Just an example of typical paradoxical breathing in a patient with acute Guillain-Barré syndrome. This gentleman is obviously uncomfortable, needs a pillow to breathe on his own. So there's some degree of orthopnea. And you can see when the chest expands, the abdomen is drawn in. And when he breathes out, the abdomen distends, which means the efficiency of air movement is reduced. Now, the standard clinical tests that we need to do regularly start with vital capacity. And for assessing the strength of muscles, we tend to use slower vital capacity rather than forced vital capacity, as the pulmonologists generally use, because that also assesses airways obstruction, which interests us less. However, the inspiratory pressures, which are tested with a simple spirometer that measures the pressures, obviously, also a very simple test, are also of importance. And we know that certain values, more than 80 centimeters inspiratory negative pressure, means that neuromuscular respiratory failure is fairly unlikely. And we can also assess prognosis along the course with the pressures that the patients achieve. For instance, a normal inspiratory pressure in ALS means that mechanical ventilation, at least in these patients, will not be needed in the next few months. Similarly, expiratory pressure it can also be used to assess the ability to cough and clear the lungs, also an important parameter, obviously. We also measure peak cough flow, and that directly measures the strength of airway clearance in cough and correlates with expiratory pressure. This is a parameter that you need particularly in intubated patients to assess the chance of successful extubation. As you know, there are no very good parameters to assess whether an attempted extubation in a ventilated patient will be successful. But the peak cough flow is one value that will show us possibly a risk of aspiration further down the line after immediate extubation success. Now, in chronic neuromuscular disorders, there are a couple of other parameters that we need to observe. In some patients who have orofacial weakness, it's difficult actually to achieve sealing of the spirometer, and then we need to use sniff pressures by measuring nasal pressures achieved if the facial weakness stops us from a standard spirometry. But we also need to assess indirect values. Overnight pulse oximetry is important to look for nocturnal hyperventilation. Transcutaneous capnography, CO2 measurement, is possibly more valued because we notice a change in CO2 values before the patients actually become hypoxic, but it's not quite as widely used at the moment, certainly not in the UK. In the US and European countries, possibly a little bit more at this point. But it correlates well with nocturnal hyperventilation as well. And the newest development is probably imaging of respiratory muscles, because all our tests at the moment are dependent on patient ability to cooperate. And of course, in children, that's going to be difficult, in other patients also. And here it can help to look at the respiratory muscles via MRI scanning, for instance. If you look at these three studies, you can see very well that the respiratory muscles are increasingly atrophic from a control on the left to a non-ambulatory severe Duchenne patient on the right, and this signifies fatty degeneration of respiratory muscles as of the limb muscles. With an MRI, at the moment, you can measure the intercostal muscle thickness, but also dynamic MRI can show chest wall movement during inspiration, which is an additional functional measure. I have no experience of gas exchange measurements by MRI myself, but this is also a possibility with xenon contrast MRI in recent years, which is something that will be of interest in future management. So what do we do in a neuromuscular clinic? I've taken this from my friend Stefan Weniger's clinic in Munich. This is a standard approach to respiratory assessment if you're seeing neuromuscular patients. So we need to ask directly for symptoms of respiratory weakness, which might be indirect: daytime sleepiness, hypersomnia, fatiguing, might all be a sign of developing respiratory failure. Morning headaches, cognitive changes, mood change, and obviously reduced endurance. Discomfort, for instance, in physiotherapy in water is a sign, because that increases to some degree the work of breathing, and sleep disturbances. Now, later symptoms that you can possibly elicit in your history will be exercise dyspnea, dyspnea at various different situations, and recurrent infections, very important. You look, as we said before, for activation of accessory respiratory muscles and paradoxical breathing. That would signify quite an advanced stage of respiratory failure. You can test cough, listen for a weak cough. And in the sleep observation, increased snoring, pauses, stop breathing related to obstructive sleep apnea, abrupt awakenings as something that the patients will report, dry mouth, elevated blood pressure, various other general symptoms. It is standard of care to perform these baseline tests regularly. When a patient comes to clinic, I would do this every time you see the patient. It doesn't take much time or effort. You assess the muscle weakness generally, but also bulbar and breathing muscles, clinical assessment of the unspecific symptoms, your history, and these values, vital capacity, cough flow, inspiratory, expiratory pressures. Similarly, perhaps less frequently, you will look for a full respiratory assessment, FVC, gas flows, capillary blood gas analyses, and in patients who are on home ventilation, you need to judge the hours of ventilation needed. You look at their sleep quality with or without ventilation and check blood gases on the ventilator and after stopping it. And then there are specialized care aspects of neurorespiratory management, more extensive respiratory assessments in the chest lab, possibly electrophysiology. There are a number of tests that can give you an idea of respiratory muscles and might be useful in some cases: phrenic nerve stimulation, electromyography of the diaphragm, for instance. However, I must say I've never found electrophysiologists very keen to do this. And personally, although you can perform EMG of the diaphragm, there is always a risk of pneumothorax, obviously. Ultrasound, on the other hand, is a less invasive way to assess the function of respiratory muscles and has begun to be used in specialized centers. We should also perform sleep studies when the preliminary tests give us a suspicion, and continuous oxygen and carbon dioxide measurements are easiest there. And in mechanically ventilated patients, the additional tests, blood gas analyses, etc. Now, what are the conditions that are likely to present with respiratory failure early along the course? Now, this is a short list here. There are obviously more. The intensivists are most familiar with Guillain-Barré syndrome, obviously, and tend to see all neuromuscular conditions through that lens, although the respiratory aspects might be different. Less frequently, severe acute neuropathies of other sort, drug-induced, others. the acute flaccid paralysis syndrome with various infective diseases, together with encephalitis in some cases, Zika, West Nile virus, various others. 10% of ALS patients will not present with the typical limb weakness. They will present with respiratory problems. Obviously, myasthenic crisis is defined by respiratory problems and other disorders of the neuromuscular junction. In many countries also organophosphate poisoning and other forms of toxicity might affect the neuromuscular junction and respiration. Various forms of acute myopathies, inflammatory myopathies, I think I left out the inflammatory there, can present with respiratory problems in myositis, particularly anti-SRP related myositis. A fairly new entity is immune checkpoint inhibitor related myasthenia, and sometimes together with myositis, and also other drug effects. And obviously advanced chronic conditions might have developed very slowly and present only with respiratory failure. And I've got an example of this here. Now, going back to very acute GBS type neuromuscular disease, in which we have the most experience in critical care, the question is always which patients need to be monitored on the ICU rather than a general ward, with availability of intubation, ventilation without delay. And here, intensivists tend to use the 20-30-40 rule, which signifies a forced vital capacity for less than 20 milliliters per kilogram, a peak inspiratory pressure of less than minus 30 centimeters water, or a peak expiratory pressure of less than 40, and also weak cough, developing in a patient whose condition is worsening, will signify they should be at the very least on an ICU with readiness for respiratory support. And this is Dr. Wadick's plan for respiratory monitoring, ICU management in Guillain-Barré syndrome, which you can translate to other very acutely developing neuromuscular disorders. Now, just to mention a few of the genetic or degenerative, in this case, neurogenic disorders that can present with respiratory failure. With neuropathies, you notice this most often in MFN2 mutations, and in this particular form of CMT2 TRPV4, which is a particular clinical picture of early stridor and diaphragmatic failure. Other forms of CNT in certain cases may present with early respiratory failure, and of course the SMA variants with respiratory deficiency, as you can see here. And beside these neurogenic conditions with early respiratory failure are the childhood spinal muscular atrophies. Kennedy's disease can present with respiratory problems. If you see the patient, you will find other signs of SBMA, but they may have gone unnoticed for many years. And finally, ALS. Now moving to the myopathies that will present with respiratory failure. This is a table of looking at those that prevent frequently and early, and they're particularly the sarcoglycanopathies, FKRP, some that are more likely to present at an advanced stage, and there are some myopathies where respiratory failure is distinctly uncommon and less of a worry, the commoner of these being dysferlinopathy and ANO5 related limb-girdle dystrophy, where respiratory failure is generally not a feature, and obviously you take that into account in your muscle clinic investigations. Now, this is a case of a patient I saw a number of years ago, a gentleman who got married, fit and well, went hiking in the Rocky Mountains, and at about 2,500 meters altitude, developed shortness of breath and then acute respiratory failure. And he was intubated, diagnosed with suspected GBS, and treated with IVIG, several courses in a hospital in San Francisco, but didn't improve. And after some weeks, he was transferred back to the UK, possibly when he ran out of money. In any case, he was admitted to our unit with a diagnosis of refractory GBS, but we noticed that he had wasted calves, contractures of the toes, and we thought we needed to look into a more chronic disorder, and the EMG was actually strikingly myopathic, which led to this muscle biopsy. And there you can see on the left the disrupted myofibrillar structure on the NADH stain with rubbed out areas you can see quite well. They're on the left. And on the right, you can see this myotilin immunostain showing myotilin accumulation in some muscle cells. And at that time, we sent in material for genetic analysis, looking for titinopathy and various other conditions, but this took a while. So we actually made the diagnosis more likely by looking at his muscle MRI, where you can see this particular pattern of involvement of specific calf on the top and upper leg muscles on the bottom, which also is quite typical for a titinopathy, which turned out to be his diagnosis. He was diagnosed with HMIRF, hereditary myopathy with early respiratory failure, and this is a fairly typical course for this condition, which is more common in Scandinavia than in many other countries. Now, other muscle disorders with isolated respiratory failure are sort of on your list if you see a patient with myopathy and early weakness of breathing. First of all, you do need to think about Pompe disease in all such cases, and they will often present with exercise intolerance, first of all. But mitochondrial disorders can also have early respiratory failure as a feature. Other myofibrillar myopathies, desminopathy is the commoner one, but also others. Various limb-girdle dystrophies, as I said before, particularly FKRP in my experience. Oculopharyngodistal muscular dystrophy may on occasion present with respiratory failure, and perhaps more frequently congenital myopathies with a fairly static course for many years, but then respiratory failure is a major feature. Nemaline rods, etc., SEPN1 myopathy. Now, this is a second case that shows you the pitfalls in making the diagnosis in these patients. So this is a case that we got wrong initially. This is a 31-year-old man who presented to respiratory medicine. He'd had 3 years of fatigue and exercise intolerance, although he was fit and well before then. They found him to have chronic neuromuscular failure, an elevated creatine kinase. He was found to have a myopathic EMG. And the respiratory physicians took a Pompe screen from the dried blood spot. Now, I didn't see a formal report in the notes, but it was said to be normal. He'd been obviously under treatment for quite some time by then. So we accepted this, did a muscle biopsy, and that was said to be dystrophic, no glycogen storage, but the pathologist did note an increase in acid phosphatase at the time. And we went on to do a NGS panel for limb-girdle dystrophies, including Pompe hotspots, and that was negative. So we didn't have the diagnosis at that time. At some point or other, we did note that the formal Pompe screen report just wasn't in the notes. And before we get to that, this is on the right, the increased acid phosphatase in the muscle biopsy, which may have been a pointer had we given it enough attention. And we found by contacting the external lab that the Pompe screen was actually positive. So this man had reduced alpha-glycosidase activity. We looked at the NGS screen, and if you went into detail, there was one pathogenic variant. And on the other hand, there was the possibility of a deletion which wasn't detected by the NGS screen. And so we went to full sequencing, and there we discovered an actual deletion that had not been observed on NGS screens. So in actual fact, the simple Pompe blood spot screen was the most reliable test here in this case, and very easy to do rather than going for the high tech. Now, a couple of aspects of respiratory management in Pompe disease. So, as you know, residual GAA activity, alpha-glucosidase activity, will define the range of severity from infantile to adult late onset. And the late onset patients, fortunately, do not have cardiopathy early on, but they do develop a progressive decline of ventilatory capacity. And this is mainly due to diaphragmatic weakness. It's the infantile case with the macroglossia. And there are also complications in infantile case of airways collapse and tracheomalacia. Now, hyperventilation and sleep disordered breathing may be early features. There are differences in the response to treatment in these patients that you can that is defined by the residual glucosidase activity, and this cross-reacting immunogenic material that you see in fibroblast Western blots will tell you whether the later respiratory treatment might be less effective due to circulating antibodies. And immunotherapy may possibly help in these patients. Important thing to know is that if you interrupt treatment for a length of time, several months, this may not be recoverable by resuming enzyme treatment. And we noticed that in a number of cases during the COVID epidemic when enzyme replacement therapy was interrupted. Now, going to a different condition, myasthenia gravis also causes neuromuscular respiratory weakness, but it's also features fatigability, as you can see in this graph with the fall off of vital capacity more rapid than the normal cases would have shown. And this often depends on the treatment you're providing. This is a patient who had intermittent shortness of breath, and you can see the vital capacity dips before the first dose of pyridostigmine, dips again before a midday dose, dips again before the evening dose. So you can you need to observe the course of respiratory function in myasthenia patients and not rely on a single test. Myasthenia patients also can develop rapid fatiguing of respiratory muscles through increased work of breathing. If they get a chest infection, they may crash. If they exert themselves more than they should, or indeed with psychological stress leading to more rapid breathing and increased work of breathing. Respiratory weakness is also an additional cardiovascular risk. And I remember very well a young patient who we lost, who had been discharged from ITU to the ward too early. There developed respiratory failure. Before it was recognized, she had a myocardial infarct at 29. And although she was salvaged at that point, some months later, she had a fatal episode of dysrhythmia following the myocardial infarct. So this is more of a danger than you might possibly recognize. Now, respiratory fatiguing will reduce exercise capacity, and high doses of pyridostigmine also increase the tendency to airways obstruction and may increase the work of breathing. So it can be a vicious cycle here. Hopefully, the novel treatments in myasthenia, including things like CAR-T therapy, which is the newest, may be effective in very advanced cases, and that remains to be seen in the next few years. You also need to consider non-muscular causes of respiratory failure. This particular patient had been stable on azathioprine for quite a few years, had stopped his medication, but later developed difficulty breathing, and this was then found to be due to a mass in his pharynx, which was an Epstein-Barr positive lymphoproliferative disorder, which is considered a possible complication of long-term azathioprine. So this man's problem was possibly related to our standard myasthenia treatment. Inflammatory myopathies. So there are a few forms of myositis that the risk is indicated by muscle-specific antibodies in particular cases, anti-SRP, anti-synthetase syndromes, and MDA5-related myositis particularly often feature respiratory weakness. And in ASS and MDA5, interstitial lung disease is an additional feature, not in SRP. The ILD may actually progress even when we have the muscle weakness under control, and this has been a major problem in the past in otherwise well-controlled standard treatment of myositis. There are a few reports now that CAR-T cell therapy may help in these refractory cases, but it remains to be established. Now, symptomatic treatment. We still have a bit of time. Respiratory muscle training is extremely important in the early stages, particularly breathing, coughing exercises, exercise, inspiratory muscle training through respiratory physicians, and expiratory training, obviously. Cough assistance is the next step when your cough function is severely impaired. And there are a number of techniques for cough augmentation, chest wall oscillations, mechanically assisted cough, and mechanical insufflation-exsufflation exercises. There is an a value below PCF of 160, where you might need to initiate cough assistance. And it is safe to a quite significantly reduced expiratory flow. At later stages, it might become a problem due to secretion retention. Ventilation options. As you know, CPAP is generally the first used, but CPAP is not helpful in severe weakness because we provide one elevated level of pressure, and there you need to go to BiPAP, where the expiratory pressure is lowered. And this may change through the patient's course. So one mode of ventilation might not be right at a later stage, and we need to continually reassess this. Now, the increased role of home ventilation also means that remote monitoring is more important. Patients and carers need to be well instructed in managing the technology. The patient needs to be the expert. And invasive monitoring is becoming more user-friendly, but as you see, you need a fair amount of kit for this. And on the other hand, on the hospital side, there needs to be a consistent response to alarms, always guaranteed. So you're not exactly saving manpower necessarily. You're saving trouble to the patient to have to come into the hospital for any assessment. Telemonitoring, all kinds of kit available for that. Wrist-warns, otherwise wearables, as we call them, various bits of equipment. We provide our patients with home spirometry quite early on, and they can monitor their own progress. Home ventilation can be initiated truly at home, and that has been well proved with an organized support system, as by the Dutch group shown here, and many manufacturers of ventilators feature now cloud-based platforms for remote monitoring of various sorts. So the dependence on hospital visits is becoming less and less. Again, lots of wearables. It would be great if we could reduce all that. Everybody has a mobile phone. All this other kit is quite intrusive. So what might we be able to do with mobile phones in telemonitoring? Well, Pascal Laforêt in Paris has, with the help of a company, Adcientium, looking at mobile phone software, have provided parameters for monitoring myasthenia patients. You can use facial recognition, as you see here, to judge features like, for instance, ptosis or eye movements. You can use voice recording systems available on mobile phones to judge dysarthria and phonation related to respiratory weakness. You can look at accelerometer data from the mobile phone to look at sit to stands, mobility, and the like. This is all possible with a standard smartphone, and I think is part of the future, at least, of telemonitoring at home. And of course, with artificial intelligence analysis of biomarkers, basically glorified number crunching, you can interpret data rather quicker than before. And this has been used in clinical studies on ALS, for instance. Telehealth-based rehabilitation is an option for patients at home. Exercises, range of motion, resistance exercises, but also respiratory exercises, looking at lung recruitment, airway clearance, and respiratory muscle training, as we mentioned before. And there is a YouTube showing respiratory telerehab that can be accessed. This is all helping to make the patients themselves more independent and able to pick up early changes. the American Veterans Health has started to implement mobile apps for telerehabilitation, which seem to be very doable with or without use of wearables. And the ALS Society in the US has developed programs of this type. And that was it. Thank you very much.
Thank you very much, Max. Brilliant talk, and with many learning points. I think people will profit a lot from what you've just told us. And usually we have written answer or questions for the end, but it takes some time for people to defreeze and gain the courage to put them. So I'm starting, if you don't mind. I have a few challenges that I would like to discuss with you. You pointed very well that sometimes you have very late failure of respiration in people with neuromuscular disorders, and that early signs may not be evident unless you test for sleep and for nocturnal parameters of breathing like capnography and oxygen. And so you also mentioned the 40-30-20 rule for the ventilation that is basically in the back of the head of people caring for these people in acute settings. But my recollection from doing emergency neurology a few years ago, because I stopped, is that sometimes you have some trouble convincing people who care basically for intensive care patients to assess neuromuscular patients a bit differently from the median, and we have some reasons for that. Sometimes as the very late failure installs, it may install in a very swift and quick manner, and sometimes people who deal with other causes of respiratory failure are not very used to it. And sometimes in the context, for instance, of myasthenia, which may not even be a chronic condition, it may be recent onset condition, you may have very sudden loss of capacity for ventilation. So would you mind giving us some rules of thumb how to make a good case for the intensivist on the other end of the telephone, please?
Well, I think, first of all, you need to make it clear to the intensive care specialist the particularities of the condition involved. For instance, in myasthenia, it is often that patients are underappreciated because just in the moment that they are tested briefly, they will they'll muster all their capability and provide a fairly good test, and then they will fatigue afterwards. And that is where patients are either not admitted to ICU or discharged early, pressure of beds, all that sort of thing. And that's what happened in the patient's case who I demonstrated here. And this was ultimately fatal for this lady because she was turfed out of the ICU in the early hours of the morning, appearing fairly well because of trauma arriving, and then went on to the ward, and there her increasing respiratory failure due to secretions, buildup, etc., was not appreciated until we actually did a morning ward round. And by then she'd had a myocardial infarct, with which she ultimately died. So you need to make it clear that you may have a condition which is not going to provide a single stable value and requires a longer observation. And if you do discharge them, who needs, let's say, some more significant respiratory monitoring than people might think, for instance. So you need to make it clear what condition you're dealing with. Likewise, people are often keen to give up if someone has failed extubation 3 or 6 times. And there you need to look at the approach to extubation. Is there something that's being missed? And you may need to make it clear to people that particularly patients with myasthenia or will take a long time and might need more than 6 tries, if you like. And the third thing I think which is important is you need to make it perfectly clear that for these patients it is actually not the end of the road, and that in most cases it will take time. You can extubate, you can intubate them if needed, because there is a good chance of extubation if you take enough time with some expertise. And also that these patients, I've heard this argument very often, this patient has no quality of life, we're just torturing him or her. And I have a video that I occasionally show of a patient who survived ICU, listened to all these discussions at her bed. It's not worth it for her, we should stop. She was perfectly awake, heard it all. And after we'd gone through the ICU and she'd finally survived that, and I think she's living still 5 years later, we asked her if she thought it was worth it, which she emphatically did. So you need to make it clear to people that their perception of what is a good quality of life might not be the same for someone who has a chronic neuromuscular disease.
Quite true, quite true. I have here an anonymous attendee who asks you the following: when to start NIV in patients with chronic neuromuscular disorders like ALS or SMA? Some guidelines recommend when SVC is lower than 80% of predicted, but it's not so clear. Which parameters should clinicians look at?
I think you really need to look at sleep quality, well, obviously also the gases during sleep, but also sleep quality. It's important to ask for all these symptoms of possible sleep deterioration and hyperventilation. And I must say that specific values are difficult in the acute conditions because these patients have been running at low values for a very long time, might be quite adapted. So if you take a specific number and apply it everywhere, you will be giving patients NIV quite earlier than you must. And another point is probably that NIV is well tolerated by patients who need it and less well tolerated by patients who don't. So often I think if you give it a trial and the patient adapts to it without problems and obviously feels better during the day later, then you probably needed it. On the other hand, if there is a lot of difficulty adjusting the patient to NIV, then possibly not yet. And also they will probably not cooperate and take the mask off when they're home.
Yeah, agree. Although there is a gray overlap between the two zones.
Absolutely.
So, and the other thing is we are experiencing worldwide an epidemic of obesity. And I think that is going to be a very complicating factor for treating these patients in the future. So many of these patients may have, as part of their disease, some degree of ventilatory failure at a certain point of the disease. But what about those patients who already have obstructive sleep apnea for reasons that have little to do with their neuromuscular condition? What additional difficulties and what extra care should you take in the diagnosis and treatment of those?
Well, that's a difficult one, of course, because you've got several pathologies, but you've got your obesity, which increases your work of breathing. You have your neuromuscular problem, and then you've got sleep apnea that might or might not be related to neuromuscular disease. Well, frequently, I think respiratory physicians concentrate completely on the sleep apnea aspect and like CPAP. And well, when I was in training, I tried CPAP on myself for a while and to see what it was like. And even with normal respiratory muscles, it is hard work.
Yeah,
So
it's not pleasant.
not pleasant at all. And you're actually increasing the work of expiration, which is quite difficult and often leads to retention, obviously, of secretions. So I think BiPAP is actually more helpful for respiratory patients by and large, and you need to the respiratory physicians need to be made aware of that.
Yeah, that's a good rule. Probably the first thing to think treating these patients with overlaps is not to use CPAP as a low level or entry level treatment. Yeah, I would agree with that. And I'm also an enthusiastic about all the use of the not only wearables but everyday objects like your smartphone or your smartwatch. And I think that you're right that it will change the future of monitoring of these conditions. Well, will help probably also in these kind of patients and situations. So, Max, we are now at the end of the webinar. We don't have any additional questions to answer. Thank you very much for your very insightful presentation. And I'm sure that we will have in the future other opportunities to invite you and discuss with you these kind of problems that are so useful and important for our patients. And as everybody knows, we are in the muscle month of webinars, meaning there is another webinar in a week. And this webinar, like every webinar, or almost every webinar, has been recorded and will be made available through our website afterwards. And so I finish by thanking Max and everybody for attending this webinar, and see you very soon in another meeting, another occasion. Thank you.
My pleasure. Thank you very much.
Bye-bye.
Bye-bye.